warahmatullahi wabarakatuh. I would like to thank the organizing committee for inviting the invitation for this great meeting. And today I am presenting one of my colleague case, which I called it unprotected premature stent delivery. So this is a 69 years old gentleman whose known case of long-standing diabetes mellitus, hypertension, hyperlipidemia, and ex-smoker. Previously, he had non-ST elevation myocardial infarction in 2012 and underwent a PCI to mid-LAD and mid-RCA. This time, he presented with exertional chest pain and positive TMT, for which he had a coronary angiogram. And as you see here, the diagnostic angiogram of the RCA has a patent med-stent with mild moderate disease at the distal bifurcation and focal significant disease in the mid-segments of the PDA. In the LAD, the stent is patent. He has diffuse disease in the diagonals. And this is the caudal views, which you can see a significant disease of the AV circumflex and involving the obtuse, the second and the third obtuse marginal. And the straight AP view, you can see the angulation of that circumflex. So the plan was to do a PCI to that circumflex involving the obtuse, the second and the third obtuse bifurcation. It was a radial approach, 6 French APU, 3-5 guiding catheter. He wired the both wires, both branches with a PMW wire. He tried initially with non-compliant balloon, but failed to advance the balloon. Therefore, he had compliant balloon 2030, which dilated the vessel well. And again, delivering the non-compliant balloon was difficult and failed, for which resulted in the loss of the whole system. So at that moment, he upgraded. He knows that it is difficult and complex procedure, so upgraded the system to 7.5 French power backup 3.5 guiding sheetless guide. And he rewired again the second obtuse margin with the PMW. There was a difficulty in wiring the OM3. He used the dual lumen catheter to wire that branch with the Sion wire. And he delivered and the NC balloon using the guide liner support and dilated both the branches. He was happy with the pre-dilatation and the preparation of the lesion. Therefore, he planned for delivering this stent. He used Zion's 2548 to try to stent the third obtuse marginal into the mid-AV circle. And as you see here, the huge difficulty in advancing that stent where the catheter, guide liner, all coming back. So this is failed. So he pulled back the stent and he decided to do ahead with a further pre-dilatation. And suddenly that balloon, 2.5 NC balloon, was stuck also in that catheter. And even you can see the OM wire was pulled back. So he was wondering what's going on right now. He decided just to do a clear plain cine to see exactly what is happening. And as you see clearly that the 48 stent was hanging, starting from that bifurcation, 2 OMs up to the left main, up to the aorta. So the whole 48 stent got dislodged. So he stopped. What to do next? First thing, check the patient. At that moment, patient started to have chest pain and his blood pressure is slightly going down and he's bradycardic. Started in noradrenaline and fluid. Of course, called all other teams, anesthesia, surgeon, just to keep him in as a backup. The good thing is the guide wire is still in place in the distal OM3. So the other question is, do you need to remove that stent or just keep it there? And here, because that long part of the stent was actually hanging in the aorta, I don't think it will be wise to keep it there. So yes, we decided to remove that. So we have that guide liner option, but we were unlucky in this case because the malalignment between the catheter and the stent. And as you see here, the maneuvering of the guide liner I think it's also damaging the ostium of that stent. So he was trying to sheath that stent inside the guide liner, but failed. So the second step, he tried with a small balloon. The 1.5 balloon, he tried to advance it further, but again, because of that malalignment not engaging that stent, he couldn't really pass it forward. So I think he thought maybe by inflating that balloon into the ostium of the stent and trying to retract that system into the guide and pulling it back, it will be bringing that stent together. Yes, he needed somebody to wipe his head. So what to do next? So now the scenario is different. We lost the wire and we have that dancing stent in the aorta. So he tried several loops, snares, trying to catch that stent. But unfortunately, because he couldn't really control the guide toward the left main and the stent, all his attempts failed. So he decided to change the catheter and he went with the Judkin 3.5 and wire both branches, LAD and circumflex, and try to control and direct the guide liner. And using again the 3-loop stent, he catched that ostium of the stent and retracted, and that stent was actually pulled back. So the whole system came back. And this is the stent that was retrieved. And you can see it how damaged and deformed the 48 stent. The diagnostic angio after that was the left main luckily was a clean, no damage was happened there. The mainly is the dissection in the obtuse marginal. So he changed again the guide to 7 French EBU 3.5, and with the guide liner, he further dilate and prepare the lesion very well, mainly the second obtuse marginal and mid circumflex, and he stented with 2.538 Zion Sierra with the help of the guide liner. Was dilated with a 3.0. And this is the final result of the procedure. So as a routine in my center, we use this approach to assess any complication happening in the cath lab, fetal approach. So B for predictability. And I think, yes, this complication is predicted because of the angulation, because of the calcium anatomy of the circumflex. E for the event prior to the action that drove the complication. The operator was really pushing too hard to deliver that stent. And you can see the resistance and backup of the guide liner and catheter, but he continued to do that. The treatment applied and outcome achieved, the successful snaring and dislodging using the NE snare. Advised to avoid similar complication. First of all, is you have to prepare the lesion very well. Think about calcium modification. Use imaging to assess more of the calcium and decide exactly your plan. And the life lesson learned is respect calcium and angulation and always keep your wire in place and don't lose it. So as my colleague said, that it is very low incidence, and we have the risky feature is extreme coronary angulation as our case with the tortuosity and calcification, inadequate and redilatation or debulking of the lesion, direct stenting also, and diffuse disease. And I think he covered all this algorithm very well. We started with a small balloon 1.5, if not successful, if the patient or the stent mismatch is there, try to advance that stent through the balloon with the balloon help, or if not, and the stent is in the proximal, that means we have to snare it with a snare. But if it was in the mid and proximal inside the coronaries, we can actually either with multi-wire technique to retrieve the lost stent, The last resort, if we couldn't do anything or succeed in any of these procedures, to crush it. So the take-home message from my case is don't underestimate calcium and always be prepared for potential complication related to it. Don't introduce a stent unless you prepare your lesion very well. And change your mindset and use more imaging during your routine PCI. And make it a habit when you check your unused stent, when you take it out of the catheter, check it for availability and the integrity. Thank you.